Before we start, please like, comment, and subscribe. It helps the channel grow and reach other nursing students who could use this info too.
Welcome to the Deep Dive. Today we are really plunging into, well, the absolute essentials for anyone just starting out in nursing. We're talking health assessment.
Yeah, this is truly the bedrock. We're using a study guide here from a health assessment course, NUR 216. It's packed, really, with those core ideas you absolutely have to get down early on.
Exactly. And our goal today is simple. Take all this dense info, kind of break it down, pull out the really critical bits, and help make them stick. Think of it as a faster track to understanding, how you figure out what's happening with a patient.
It really boils down to learning how to gather information properly, systematically.
Okay, so let's jump right in. The absolute first thing, the building blocks. It's understanding the difference between subjective and objective data. This isn't just like textbook stuff. It's vital for actual care.
Oh, absolutely vital. It's the very first distinction. So subjective data, that's anything the patient or maybe their family reports to you. It's their words, their feelings, how they describe their symptoms. And really importantly, basically all the info you get in that health history interview, that's subjective.
Okay, so if a patient says, my head hurts or I feel really nauseous, that's subjective. It's coming from them.
Precisely. It's their experience. Now, objective data, that's different. That's what you, the nurse, can physically see or measure or observe.
Like vital signs, temperature, blood pressure.
Vital signs are a perfect example, yeah. Objective. Also, what you actually find during your physical assessment, looking at their skin, listening to their lungs, feeling for swelling, lab results, diagnostic test results, also objective. It's the stuff you can verify.
So subjective is said, objective is seen or measured.
Got it.
But why is getting that distinction so clear right at the start so important for a new nurse?
Well, because you need both pieces for the whole picture, right? But they play different roles. Subjective tells you the patient's story, what matters to them. Objective gives you the hard evidence, the physical facts. Sometimes they match up perfectly, sometimes not so much. Your job is to collect both and figure out how they fit together.
Okay, that makes sense. And getting that subjective story, especially the history, means you've got to be good at communicating, how you ask questions. That seems foundational.
Yeah.
Let's talk open-ended versus closed-ended.
Yeah, these are your main tools for that interview. Open-ended questions. They're broad. They invite the patient to share, like, tell me more about that, or what brings you in today. You use these right at the start to get the whole picture without putting words in their mouth.
And closed-ended. Those are the short answer ones, yes, no.
Direct. Usually looking for a simple yes, no, or a very specific fact. Now, you use these, but sparingly. They aren't good for opening up the conversation. They kind of shut it down. They're best used after you've got the general story, maybe just to clarify one little detail.
Okay, so start wide, let them talk, then narrow in with closed questions if you need a specific fact.
Right.
Makes sense. And it's not just the type of question, is it? There are ways to talk with a patient. Therapeutic communication.
Absolutely. Building that trust is, well, everything. If you want accurate, subjective information, key strategies. Things like making observations. I notice you're rubbing your shoulder, or I heard you say this feels worse at night. It shows you're really listening. And things like restating, reflecting, summarizing what they said. It confirms you're understanding them and encourages them to add more. And empathy. Huge. Just acknowledging how scary or difficult something must be for them. This must be very frightening for you.
It feels like it's about really connecting with what they're going through. The main idea is always encouraging them to express themselves, right? Which, again, points back to those open-ended questions.
Exactly. And just as vital as what you should do is knowing what to avoid, there are definite communication pitfalls.
Like asking why. And I remember reading that can be tricky.
It really can. Asking why can make people feel defensive, like they have to justify themselves. Also, definitely avoid telling patients what they should do, You should really get your daughter to help with that. It undermines their own decision-making.
Right. Making assumptions. The guide mentioned something like assuming someone wants a chaplain called just based on, well, anything other than them asking.
Spot on. Never assume. Ask. And another big one. Avoid false reassurance. Saying things like, oh, don't worry, everything will be fine, or making promises you might not be able to keep, like, I promise I'll check on you every hour on the hour. If things aren't fine or you get swamped, you've broken that trust.
And obviously don't accuse them of not telling the truth or just change the subject if they're trying to talk about something important.
Yeah, the goal is always that safe, open environment where they feel comfortable sharing.
Okay, and creating that environment.
Yeah.
It starts even before the actual assessment questions, right?
Yeah.
Setting the scene properly.
Oh, definitely. Basic, but crucial. Wash your hands. Introduce yourself. Explain who you are and what you're doing. And privacy is non-negotiable. Close the curtain, shut the door, respect their dignity.
And you should tell them the plan before you start. Like, okay, first I'm going to ask you some questions about your health history, and then I'll take your vital signs. Managing expectations helps reduce anxiety.
For sure. Also, think about timing. Sensitive topics, maybe wait until you've built a bit of rapport before diving into things like sexual history or substance use. Don't lead with that.
Your own body language matters too.
No.
Making eye contact, not looking rushed, maybe sitting down at their eye level instead of towering over them. It signals you're present.
Yes, absolutely. And always, always encourage them to ask you questions. Let them know it's okay. Regarding the physical exam part, only have them gown up if it's really needed for what you need to assess and cover them back up quickly. Maintain their modesty.
What about when family or friends are there? The guide mentions support persons.
Patients can definitely have support people present. But remember, if the patient is 18 or over and competent, they make the decisions. Always address the patient directly, even if a family member tries to answer for them. Focus on the patient.
That makes sense. It respects their autonomy. And this all flows into being culturally competent, providing inclusive care.
Right. It's about treating the interaction as fundamentally human. It's not about pretending everyone's the same. It's about respecting and understanding differences.
And checking your own biases, assumptions, creating an environment where the patient feels safe and respected no matter their background. Simple things like asking their preferred name and pronoun can make a huge difference.
All these steps really lay the foundation so you can get that detailed health history effectively.
Okay, so let's walk through that history itself, the structure. It's not random, there's a flow. Starting with the reason for seeking care, or the chief complaint.
Exactly. That's the patient's short statement, usually in their own words, about why they're here today. Just a few words, typically. Chest pains, sore throat, follow-up appointment.
The headline. Then you dig deeper with the history of present illness, the HPI. That's the story behind the headline.
Precisely. The HPI is where you get the details. It's a narrative, a paragraph really, all about the main symptom or symptoms that brought them in. And this is prime territory for those open-ended questions to get them started.
And to make sure you cover all the important details for that HPI, the guide gives us that great acronym, OLDCARTS.
OLDCARTS is fantastic. It's like a mental checklist to make sure you ask about all the key characteristics of a symptom. So O is onset, when did it start? L is location, where exactly do you feel it? D is duration, how long does it last when it happens? C is characteristics, what does it feel like? Is the pain sharp, dull? Is the cough wet, dry?
Then A, aggravating and alleviating factors. What makes it worse? What makes it better? Or related symptoms? Anything else happen along with it? Like feeling dizzy when the pain hits? Treatments, what have you already tried for this? And S is severity. How bad is it? Often using a pain scale, 0 to 10.
Using OLDCARTS systematically helps you paint a really complete picture of that main problem. But the history is more than just the current issue, right? You also need their past medical history, that includes mental health history too, and any past surgery.
And medications, a complete list. Not just prescriptions, but over-the-counter stuff, vitamins, herbal supplements, everything. You need to know if they're taking, say, blood pressure meds or maybe St. John's wort that they forgot to mention.
Very important. Then there's the functional assessment. How are they managing their activities of daily living ADLs? You know, dressing, bathing, feeding themselves. This is critical for identifying safety issues.
So if you notice they mention new problems with hearing or seeing or maybe numbness in their feet, neuropathy, it's not just a finding, it's a potential safety risk you need to flag.
Exactly right. Safety first. Family history is also key. Are there patterns? Multiple relatives with heart disease, diabetes, certain cancers. This helps you assess risk factors.
Okay. And then the review of systems. That sounds like a big checklist.
It kind of is. It's a systematic run-through, usually head to toe, asking about common symptoms in each body system. It helps catch things the patient might not have mentioned because they were focused on their main complaint.
So you'd ask about, like, vision changes, hearing loss, shortness of breath, chest pain, nausea, problems urinating, headaches, joint pain, just covering the bases for each system.
Precisely. It's a safety net to make sure nothing significant gets missed. Now, the guide makes a really important point about emergencies.
Right, if someone's really sick.
You don't delay treatment for a perfect lengthy history or exam. If they're alert enough, you might be doing both simultaneously, asking quick questions while starting your physical assessment to get the crucial info needed for immediate action.
Speed is key then. but still grabbing what subjective info you can.
Yes. And finally, there's the basic biographical data name, age, race, occupation, marital status, etc., the demographics.
Okay, that covers the subjective side pretty thoroughly. Let's switch to the objective data collection, starting with the general survey. This is your observation kicking in.
Yeah, the general survey is literally your first look. It starts the second you see the patient. It's the start of the physical assessment, your overall first impression, using your senses.
What are you looking for? Things like their hygiene, grooming, how they seem emotionally, just their general appearance, body build. Are they restless? Is their speech okay? How they move, their posture, and their mental status.
Mental status is a huge piece of that initial survey. Usually you're assessing if they're alert and oriented ×4 or A and OX4.
And those 4 things are?
Person, do they know their name, date of birth? Place, do they know where they are? Time, do they know the date, month, year? And situation, do they understand why they're there? It's a quick check of their basic cognitive awareness.
Gotcha. Now, a topic that kind of bridges subjective and objective is pain. The guide really stresses advocating for good pain control.
So important. And the gold standard for assessing pain, assuming the patient can communicate, is alert and oriented is their self-report. Whatever number they give you, whatever they say their pain is, that is their pain level, period.
But what if they say no pain, but they look like they're hurting, guarding, grimacing?
That's where your skills come in again. The guide suggests maybe using different words. Instead of pain, ask about discomfort, soreness, aching. Use those open-ended questions to gently explore it further.
You have those objective signs too, the nonverbal cues.
Exactly. Things you observe, grimacing, maybe guarding their abdomen, moaning, even changes in vital signs like heart rate, breathing rate, blood pressure going up can signal pain, especially if they can't tell you verbally.
It seems crucial to let patients know you take their pain seriously.
Absolutely. Reassure them it's a priority. And know when you need to act. The guide is clear. If pain is interfering with their daily activities, their mobility, or if it's severe like a 7 out of 10 or higher, that's always a concern, always a priority. You need to notify the provider. Mild post-op pain might be expected, but severe pain isn't.
And assessing pain isn't a one-time thing, is it? You have to reassess after you do something.
Reassessment is critical. How else do you know if your intervention worked? You use the same method you started with, ask for their rating, look for nonverbal cues, check vitals. If their vitals are heading back towards their normal range, that's a good objective sign the intervention helped.
And the timing depends on what you did, right? Non-drug versus drug interventions.
Correct. For non-pharmacological things, repositioning, ice, heat, you'd reassess maybe in 15 minutes or so. For medications, you give them more time to work, usually reassessing in 30 to 60 minutes.
And documenting clearly is key, not just pain better.
Oh, definitely not. Be specific. Patient reports pain decreased from an 810 to a 310 30 minutes after receiving morphine. That level of detail is vital.
Okay, let's talk vital signs, those core objective numbers. First tip from the source. If a UAP unlicensed assistive personnel gets an abnormal vital sign, you, the nurse, need to recheck it yourself.
Absolutely. Verify critical data. So blood pressure, BP, normal is generally less than 120 over less than 80. Low is hypotension, high is hypertension.
And getting it right means good technique. Right cuff size, snug fit, feeling for the brachial artery pulse, legs uncrossed, no smoking right before. All that matters.
Yep. And watch out for orthostatic hypotension. That's when the BP drops significantly, like more than 20 points systolic, or the pulse jumps up more than 20 beats when they go from lying down to sitting or standing. Big fall risk. You need to check for that sometimes.
Temperature? Normal varies a bit, right? Person to person, how you take it.
It does. Always good to know their baseline, if possible. Core temps, tympanic, ear, temporal, forehead, rectal are generally most accurate. Rectal is invasive, though, and you wouldn't do it if they have rectal issues or diarrhea. Only insert about 1-2 inches for an adult.
Oral temp is easier but less accurate. Surface reading.
Right. And things like smoking, hot or cold drinks affect it need to wait 30 minutes. And you wouldn't use oral if they're nauseous, vomiting, or had facial trauma.
Pulse or heart rate, HR.
Right.
Normal is 60 to 100 beats per minute.
Usually. Very fit athletes might be lower, maybe 40 to 60, and that's normal for them. Below 60 is bradycardia, above 100 is tachycardia. An abnormal heart rate can be a really early warning sign of distress, so it's a priority if it's off.
Respiratory rate, RR, breaths per minute. Normal 12 to 18.
That's the typical range. Slower is bradypnea, faster over 20 is tachypnea.
Impulse oximetry, SpO2. Oxygen level.
Measures oxygen saturation, usually wanted above 94%. These vitals give you quick, objective data points. Crucial.
The guide also touches briefly on nutrition assessment.
Yeah, it mentions BMI body mass index, calculated from weight and height. Good to know the ranges. Underweight below 18.5, normal 18.5, 24.9, overweight 25, 29.9, obese 30 and up, with different classes of obesity. And it flags the increased risk for diabetes and heart disease with overweight and obesity.
So part of the assessment might be checking their understanding and maybe offering some education.
Could be. Also direct observation, like watching them eat. Can you see how much they're eating? Are they having any trouble chewing or swallowing?
And swallowing problems are a huge safety issue, right? Aspiration risk.
The biggest risk, really. Compromises the airway, the ABCs. The guide also mentions risk factors for malnutrition, things like alcohol use, being elderly, having chronic diseases, poverty, and unintentional weight loss. That can be a sign of serious underlying illness, like cancer. You need to investigate that.
Okay, let's shift to the actual hands-on physical assessment techniques. The guide outlines the standard order for most systems.
That usual sequence is inspection, palpation, percussion, and auscultation, IPPA.
So inspection is just looking.
Looking and smelling, yeah. Careful observation. What do you see? Any unusual odors?
Palpation is using touch.
Right. Using your hands, fingers to feel, assessing things like temperature, texture, moisture, tenderness, lumps, bumps. Finger pads are best for fine details like pulses or skin texture.
Percussion, that's the tapping.
Yep. Tapping on the body surface to create sounds. The sound tells you about what's underneath. Is it air-filled, fluid-filled, solid? You listen to the pitch, loudness, duration, quality of that sound.
And auscultation is listening with a stethoscope.
Usually with a stethoscope, yeah.
Yep.
Listening to sounds inside the body, heart, lungs, bowels. You can do direct auscultation too, just listening with your ear. But the guide notes, if you do that for bowel sounds, listen for a full minute.
And using that stethoscope correctly is important.
Definitely. Place it directly on the skin, firmly. The diaphragm, the big flat side, is for high-pitched sounds. Think breath sounds, normal bowel sounds. The bell, the smaller cup side, is for low-pitched sounds, like certain heart murmurs or vascular sounds called brutes.
The other tool mentioned is the sphygmomanometer, BP cuff.
Essential piece of kit for getting that blood pressure accurately.
Okay. Throughout all of this, patient rights are key. The guide calls out a couple specifically.
Confidentiality is huge. HIPAA. Always get the patient's permission before discussing anything sensitive if others are in the room. It's their private information.
And transparency. Share your findings. Let them know their BP reading, what you heard in their lungs. It empowers them.
Absolutely. Now, as you gather all this data, subjective and objective, a really critical skill, especially for students, is prioritization. You can't fix everything at once. You have to figure out what's most important now. The guide offers some good thinking prompts.
Questions to help you sort through it all. Like, if I could only do one thing right now, what would it be? Or, what's the biggest safety concern here? Which finding is the most abnormal or worrying?
Exactly. Does this finding seriously affect their ability to function safely? How far off are the vitals? Are multiple vitals abnormal? Asking yourself these questions helps you zero in on the top priorities for that patient at that moment.
And finally, the guide links all this assessment data back to practical tasks, specifically mentioning MedMath. It shows how the information you collect is directly used.
Right. It's not just gathering info for its own sake. It has direct application. Like calculating BMI, you need their weight in kg and height in meters squared. You get that weight and height during your assessment.
Yeah, the example, 1.65 meters tall, 104 pounds. First step is converting pounds to kilograms. 1 kilogram is 2.2 pounds, using the patient's measured weight. You can't do the BMI calculation without that specific assessment data in the right units.
Precisely. Same for dosage calculations. Order for furosemide 40 milligrams, vial says 20 mg/ml. You use the assessed need, the order, and the available concentration objective info to calculate you need 2 mml.
Or figuring out tablets. Order for carvedilol 12.5 milligram, pills are 25 milligrams. Basic math using the order and the available dose tells you to give half a tablet.
It perfectly illustrates how that assessment data, both subjective need and objective measurements or available drug forms, directly informs safe medication administration. It all connects.
Wow, okay. That was a really thorough deep dive into the absolute cornerstones of health assessment for anyone starting in nursing. We hit subjective versus objective, communication techniques, setting the stage, the whole health history structure with OLDCARTS, the general survey, pain, vitals, nutrition basics, those physical exam techniques, patient rights, prioritization, and even how it links to things like MedMath.
It really is the foundation. Getting comfortable and skilled with these things is just, well, it's essential for understanding your patients and giving safe, truly effective care.
So as you, the listener, get ready to put these skills into practice, maybe think about this. How does the actual care and attention you put into gathering both that personal story and the objective facts truly shape every single thing you do next in that patient's plan of care?
It's the starting point for everything else you'll build.
Definitely something to keep in mind as you step onto the floor. Thanks for joining us for this deep dive.